স্যার এখন থেকে স্যার 10 সেকেন্ড পরে থেকে কথা বলা শুরু করলে হবে স্যার। Just after 10 seconds you can start your talk, sir. Sir, শুরু করেন স্যার।
Good evening, dear participants, distinguished faculties. Especially, we are honored with Dr. Rafique Ahmed, sir, Dr. Ullah from USA, Professor M.G. Azam, Dr. A.M. Shafique, Dr. Navin Sheikh from Bangabandhu Medical University, and many more. So, today there are two speakers. The first speaker is me, followed by Dr. A.M. Shafique. My talk will be on T waves, and Dr. A.M. Shafique will talk on some case-based discussion. So, Dr. Rafique Ahmed, sir. Hello, sir. Also, we can see Dr. Naharuma Haidar. Welcome, Dr. Naharuma Haidar.
And thank you, sir. Bhalo achen, sir.
Hey, bhalo achi, Naharuma. Navin Sheikh. We can also see Dr. Navin Sheikh. Welcome, Dr. Navin Sheikh.
Ji, assalamu alaikum.
Wa alaikum salam, Navin Sheikh. After a long time, we are very much happy to see you, Dr. Navin Sheikh. M.G. Azam, are you here? Dr. M.G. Azam. So I'm waiting for Dr. Rafique Ahmed, sir. Sir. M.G. Azam.
Sir.
Now you are here. We can start, Dr. M.G. Azam, Professor M.G. Azam.
Sir, shuru kore den, sir. Shuru kore den, sir.
I'm waiting for Dr. Rafique Ahmed, sir.
Oh, sir. Bodhe fresh room gese bodhe অপেক্ষা করি স্যার 1-2 মিনিট।
Welcome, Dr. Abdul Jamil. Jamil, can you hear us?
Assalamu alaikum.
Wa alaikum assalam, Jamil. Dr. Jamil.
Yes.
Actually, Professor Wadud is on the way. Tushar is not here. And we are waiting for Dr. Rafique Ahmed, sir. And today, two speakers, one of the speaker, me, and another is Dr. A.M. Shafique. Welcome, Dr. Jilur Rahman. Azam.
স্যার
আচ্ছা তোমার কাছে ওই যে স্যারের নাম্বার আছে না?
হ্যাঁ 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 হ্যাঁ
স্যারকে একটু ফোন করো না।
আচ্ছা দিচ্ছি স্যার দিচ্ছি স্যার।
Welcome, Professor Wadud Chowdhury.
Assalamu alaikum.
Wa Islam. Still you are inside the car, I think.
Gari madhe.
চৌধুরী
জি জি আতার ভাই
আচ্ছা আমি আপনাকে রিকোয়েস্ট করছি ইউ ক্যান স্টার্ট দ্য প্রোগ্রাম তুষার নাই আর কি
আচ্ছা good evening everybody. Today we are in a very hotspot condition because of the traffic jam and everything. That's very characteristic of Dhaka. Today we're going to learn about the T-wave changes, and that will be spoken about by none other than our very beloved Professor Atahar Ali. Atahar Bhai, he doesn't need any introduction to the audience who are always present here. So I'll be requesting him to start his session.
So I can share my screen now.
Yes, sir. Sure, correct.
Can you see my slide? Jamil?
Yes, we can see. We can see it.
Okay, okay. So T-wave in ECG. This is my topic of the talk. So it is difficult to interpret separately T-wave separately as because ST segment and T-wave in most of the pathologies move simultaneously. And beginning of the T-wave is not sharp as because you see the ending of the ST segment and beginning of the T-wave in most of the situation is not sharp. It is just approximation that this is the beginning of the T and this is the end of the ST segment. So this is another problem. So this is a reason why difficult to interpret. And both are part of the repolarization. Both the ST segment and T waves are part of the repolarization of the cardiac action potential. So this is the region. It is difficult to interpret or comment about the T waves separately. And again, T-wave is one of the very important component of the action potential, that is the ECG, electrophysiological concept of the ECG, is because T-wave marks the junction between the ventricular systole and diastole, is because the ventricular systole is the QT interval, that is from the beginning of the Q and the end of the T. So T-wave marks the end of the systole, and simultaneously, T-wave also marks the junction between the absolute refractory period and relative refractory period. You see, from the tip of the T, if we draw a perpendicular line, the left part is absolute refractory period and the right part is the relative refractory period. So this is the region. It is difficult to interpret T-wave separately, but still we have to learn something about the T-wave. There are some information about the T-waves, normal T-waves, as because the T-waves, the normal T-waves follows the direction of the QRS complex, the same direction. The dominant component of the QRS complex moves in which direction? The T-waves must. So as for example, you can see in the lead 2, the QRS is upright, so T-wave is upright. In AVR, the QRS complex is downward, so T-wave is downward. So this is the basic concept, that is that T-wave follows the direction of the QRS complex. And also, T-wave is physiologically and normally is negative in AVR. You see, this is the AVR and V1. AVR and V1, but this formula is not applicable in case of the bundle branch block. And the T-wave amplitude, it should be less than 15 millimeter in precordial leads from V1 to V6 and should be less than 5 millimeter in limb leads. And the normal of the T-wave is asymmetric. This is the normal. Asymmetry is the normal criteria of the T-wave. You see, this is the blue mark, that is the perpendicular line here. You can compare the left side and the right side of the T-wave, and you can see the left segment and the right segment are not similar, not similar. So this is the criteria of the asymmetry. So asymmetry is the normal criteria of the T wave. So these are the some information about the normal physiology of the T wave. And we should always remember this golden rule of impulse propagation. We know the golden rule of impulse propagation is that from an electrode, the impulse going away produces the negative deflection. As for example, you can see in this figure, this impulse is going away from this electrode, so there will be negative deflection, and it is going toward this electrode, so there will be positive deflection. This is the golden rule of ECG. So we should always remember this will be also applicable in case of the T wave. So toward the lead, positive deflection, away from the lead, negative deflection, and perpendicular to the lead. As for example, you can see from this figure, that is the perpendicular of the lead, that is there will be biphasic. So depending on the amount of the perpendicularity, so there will be the positive and negative deflection comparison. So this is the normal criteria of the electrical propagation of impulses in relation to a position of the electrode. Away from the electrode, negative, towards the electrode, positive, perpendicular to the electrode, it should be the biphasic. But in case of the T wave, QRS is the depolarization and T wave is the repolarization. So the movement should be opposite. That is, the T wave should move opposite to the direction of the repolarization. That is the depolarization. That is, it should be ideally, the T wave should be in opposite direction of the QRS complex. It should be the opposite direction of the QRS complex as because QRS represents the depolarization and T represents the repolarization, and direction of the both components are opposite. That is, the depolarization and repolarization moves in opposite direction. So T wave should be in opposite direction, but in the same direction. Why? Why both the T wave and QRS complex move in the same direction? This is one of the example you can see. That is this is one of the figure that is on the left side. You can see this is the Purkinje protein, that is the Purkinje fiber. The predominant Purkinje fibers lies sub-endocardially. So depolarization of the myocardium starts from the endocardium, and the depolarization movements goes from endocardium to epicardium. That is, from endocardium to epicardium in this direction. And usually the electrodes are placed over the endocardium with the chest wall. So depolarization is the movement of the positive. This is the positive pole of action potential. This is the positive pole. So depolarization movement means movement of the positive pole towards an electrode. So there will be some positive deflection. So depolarization produces positive deflection. That the same electrode, because of the increased intraventricular pressure, the repolarization should start from the, instead of starting from the endocardium, the repolarization again starts from the epicardium. There is movement of the repolarization from epicardium towards the endocardium. And in case of the depolarization, endocardium to epicardium. In case of repolarization, epicardium to endocardium. And this is the negative pole. That is movement of the negative pole of the action potential. So it can be assumed that negative wave traveling away is almost equal to the positive pole moving towards an electrode. That is, it is equivalent. That is, negative pole going away from this electrode means positive pole is coming toward this electrode. So the repolarization again produces the positive deflection. That is, this is the region. Both the depolarization and repolarization moves in the same direction. This is the basic concepts of ECG and electrophysiology. So this is the region why both the T wave and QRS complex move in the same direction. This is physiologically, this is the normal physiology. And these are some examples of the abnormalities of the T wave. This is the normal T wave. This is the normal T wave, that is the asymmetric normal T wave, and less than 15 millimeter in case of the precordial lead, and less than 5 millimeter in case of the limb leads. This is the normal T wave, that is the asymmetric T wave. This is the normal T wave, but T wave may be the biphasic. This is biphasic. This is like this. This is the biphasic T wave. This is the bifid. This is the one tip and another tip. So this is the bifid T wave, and This is the tall peak T wave, and this is the flat, prolonged, delayed T wave. This is the inverted T wave, and this is again inverted T wave. There are two types of inversion. So these are the examples of various abnormalities of the T wave. And in summary, the T wave abnormalities may be tall, biphasic, bifid, or flat. These are the abnormalities of the T wave. Some examples other than the normal physiology. I will give some example like this. These are the examples of the tall T wave. That is the tall T wave means definition criteria of the tall T wave means that is the 15 millimeter, 5 millimeter in case of the limb leads. The height of the T wave should be more than 5 millimeter in case of the limb leads, more than 15 millimeter in case of the precordial leads, 15 millimeter or more than half of the preceding QRS amplitude. That is the more than 50% of the preceding QRS amplitude. So either of these criteria fulfill, that is the criteria of the tall T wave. So tall T waves, there are two examples of the tall T waves. That is the hyperkalemia in case of the hyperacute ischemia. These are the two examples. So we can compare with the normal variant. This is the normal T wave. The height is less than 15 millimeters in case of the precordial lip, and asymmetric. Asymmetric, this is the one of the basic normal physiological criteria of the normal T wave. But in case of the abnormal T wave, you see symmetric. Both the left and right parts of the T wave from the starting from the peak, they similar. That is a symmetric T wave. Both in case of hyperkalemia and the hyperacute ischemia, the T waves are symmetric. But 3 points we should consider for differentiation between the hyperkalemia and hyperacute ischemia. That is the tip. Tip in case of the hyperkalemia is very pointed, sharp, like the needle. There is a very sharp pointed tip in case of the hyperkalemia. This is little rounded in case of the ischemia, little rounded in case of the ischemia. Then base is wider in case of the hyperacute ischemia. The base is narrower in case of the hyperkalemia. And symmetry, both are symmetrical, but comparing to the normal, it should be asymmetric in case of the normal. So these are the 3 points, that is the tip, base, and the symmetry. These 3 points should be considered for differentiating between the tall peak T wave in case of the hyperkalemia and the hyperacute ischemia. So tall peak T wave, there are two causes, hyperkalemia and hyperacute ischemia, and these are the points by which we can separate between these two. Some examples like this. This is one of the ECG examples. You can see the tall peak T wave. The tip is very sharp. You can see mid precordial leads, particularly the V2 to V5, V4 and V5. The T waves are very pointed and tall peak. There is a 5, 10, more than 15 millimeters amplitude. The tip is very pointed like the needle. The base is not wide, little narrower. So this can be a case of the hyperkalemia. That is the hyperkalemia. So always we have to consider the points, that is the company it keeps. That is this T wave, what are the other ECG findings it keeps in association with this finding. So we can consider, that is in this ECG we cannot see the P waves, that is the absent of the P waves, and QRS complexes are wide and it does not fulfill the criteria of the right bundle branch block or the late bundle branch block. You can see the V6 does not fulfill the criteria of the late bundle branch block. So wider QRS complex does not fulfill the criteria neither for the RBB or the LBB. It is a case of the IVCD, intraventricular conduction defects. And simultaneously, the QT is prolonged. You can see from this, in any lead, you can see the QT is prolonged. This is the ending of the key. So the QT is more than 50%. That is from here to here, you can see this is more than 50% of the cardiac cycle. So QT is prolonged. So P is absent, QRS complex, that is IVCD, QT is prolonged. All these points indicate that this might be a case of the hyperkalemia case, because all these components may be present here. And QT prolongation may be because of the hypercalcemia as well as from the hyperkalemia. So this is the way how we can differentiate the types of the tall peak T wave comparing with the ischemia. So this is the case of the hyperkalemia, and maybe in case of the chronic renal failure, as because all this can be present in case of the chronic renal failure. That is the hyperkalemia as well as the hypercalcemia. So this is one of the way. This is another examples of the tall peak T wave. You can see the T wave is tall. That is in case of the mid-pericardial leads, particularly from V2 to V5, the T waves are tall, and the tip is little rounded. The base is little wider. So this is a tall peak T wave definitely. But what is the cause? With the hyperkalemia or hyperacute ischemia. To differentiate it, we can take the help of the other findings, that is the company it keeps. We can see the T wave is positive in V1, what should not be. Actually, in case of the V1, the T wave should be negative, but in here the T wave is positive. So this is another company along with these T wave findings. Then symmetry of the T waves, that is the T wave is symmetrical, so it should not be normal. This is abnormal as because the T wave is symmetrical. The upsloping ST depression in different leads. These are the upsloping ST depression in different leads. We can see it is present in the V2, V3, in different leads, inferior lead also, the lateral lead also, in different leads. That is the global types of the ST depression with concavity upwards. So this is the upsloping ST depression in different leads. ST elevation in AVR. You can see the ST elevation in AVR. So these are the associated finding in along with the tall peak T wave, and this associated finding match with the finds of the ischemia. So that is the ST depression, ST elevation, all can be present in case of the ischemia. So this is likely a case of the hyperacute ischemia. But the another special findings in this is that this hyperacute ischemia, in case of the tall peak T wave, the ST depression usually should be convex, that it should not be concave upward. So concave upward is there some mismatch finding in case of the tall picture. So this is a case of the acute coronary syndrome, but this is some inconsistent finding, and presence of such finding along with the presence of such hyper T wave is a special variety, what is called the D Winters T wave. So this is the hyperacute ischemia, that is hyperacute T waves, and special variety is the D Winters T wave. So we can think that the T wave is not symmetrical in case of the V4 and V5, but still these are the symmetrical. Actually, the height, that is length, is not important, as because this is the first part of the T wave in V4, and this is the second part of the T wave. Actually, whether it is symmetrical or not, to consider it, we should increase the length. You see, when the length of the left is increased up to the same level, now we can see both the limbs are the symmetrical. So this is not the height. This is the symmetry of both the sides. This is the rising and declining parameter of the absolute, that is the first part and the second part of the T wave, that defines the whether it is symmetrical or not. So this is the symmetrical T waves. We are confused with the V4, V5. These are not symmetrical, but these are the symmetrical T waves. So this is the special type of the hyperacute ischemia where the ST depression is downsloping with that is the concavity upwards ST depression, and this is the special variety, that is D Winters T wave. First of all, this is the hyperacute T wave, that is tall peak T wave because of the hyperacute ischemia, and this is the special variety because of the D Winters T wave. So now the T inversions. There are some causes of the T inversion, that is the abnormal T inversion, that is the causes of the T inversion, the abnormal conduction, strain, ischemia, and chronic pericarditis. These are the causes of the T inversion. And the types of the T inversion are the primary T inversion, that is the primary problem of the repolarization. When the T inversion is because of the primary problem of the repolarization, it is called the primary T inversion. And when the T inversion is because secondary to the abnormal depolarization, as for example, in case of the bundle branch block, LVs, permanent pacemaker, or pre-excitation, these are called the secondary T inversion. So T inversion, these are the causes of the T inversion, and there are two types of the T inversion. This is one of the example. This is the, in case of the bundle branch block, particularly the late bundle branch block, the T wave should be discordant. The physiologically what we have learned, that is T wave should be concordant with the QRS complex. But in case of the bundle branch block or conduction abnormality, the T wave should be discordant. That is the QRS complex going upwards and the T wave is going downward. This is the normal in case of the, this is normal for the bundle branch. This T wave movement is normal for the bundle branch block. That is T wave is going opposite direction of the QRS complex. Like this is the T depression, and this is the T, that is the upright TF. But when the pathology happens, as for example, acute ischemia, in such cases, that is in presence of the bundle branch block or pacemaker, then what happens? That is the exaggeration of the normal physiology. Exaggeration of the normal physiology. That is, the T wave will move in the same direction. That is the concordance. Instead of the discordance, the T wave will move the concordance or excessive discordance, either concordance or excessive discordance or ST dependence. This is the Garbosai criteria. I am not going to describe this criteria, but this is what happens in case of the physiology in presence of the bundle branch block, that is discordance TFs, and in pathology in presence of the bundle branch block, discordance TF. This is the actually message from this ECG. So this is one of the examples. This is the case of the late bundle branch block. You can see this is clearly a ECG of the late bundle branch block and discordant TF. That is the predominant QRS complex going downwards and TF is going upward. This is against the normal physiology, but this is the normal physiology for the bundle branch block. The discordant TF. This is the in case of the late bundle branch block, and this is the secondary TF. In case of the right bundle branch block, the TF is going in opposite direction, that is discordance. This is physiological, and this is the secondary TF senses. And this is the again TF senses, ST depression and TFs going in opposite direction, that is discordance. And if you can see the company it keeps, there will be the short PR interval and the delta wave, that is the delta wave, and the short PR, this is the delta wave and the short PR interval. So this is obviously case of the pre-excitation, and this is also a conduction abnormality and discordance T wave. So this is secondary T wave senses, that is secondary to the depolarization, what happens in case of the pre-excitation. So another example is the biphasic T wave. There are the two types of the biphasic T wave. The biphasic T wave, two types of the biphasic. That is, the first part is positive, second part is negative. This is the biphasic T wave like this. Or first part is negative, second part is positive like this. So this is fits in case of the acute ischemia, and this is characteristics of the hypokalemia. So biphasic T waves, there are two causes, acute ischemia or the hypokalemia. Positive followed by negative ischemia, negative followed by positive in case of the hypokalemia. So this is the example. This is one of the example of ECG. You can see this is the biphasic T wave. You can see in the particularly in case of the V2, V3, V4, V5, V3, it is very much clear. That is first part is positive followed by the negative, positive followed by the negative. So this fits the ischemic criteria. So this is the this biphasic T wave is because of the acute ischemia, and company it keeps, that is the R wave is preserved. There is the normal progression of the R wave from the V1 to V6. That is the R wave progression is normal. And this type of finding even may be present in the pain-free period, and the cardiac enzyme may be normal. So this is an example of the acute ischemia, and particularly with or without presence of the chest pain or angina, either it can be acute coronary syndrome, or particularly it can fulfill the criteria of the OLN science. OLN science. When this criteria fulfills, that is the preserved R wave progression may be present in case of the pain-free period or normal cardiac enzyme. Then it is a special variety, that is OLN syndrome. Otherwise, this is acute coronary syndrome. So this is OLN syndrome is a special type of the acute coronary syndrome when this criteria fulfills. So this is the ischemic type of the biphasic T wave. This is the main message. That is ischemic type of the T wave senses, that is positive followed by the negative. This is another example of the T wave senses. Here the T wave senses is, that is the T wave. The T wave is, that is the flat, that is the, it is the some deformity of the T wave, that is the like this, that is the long T wave, there is the some spoon shape, that is the going downward. So this is a special type of the T wave. This is not like this normal T wave. So this kind of the T wave, and this is also present in globally, that is in almost all the ECG, that is the leads, it is present. So this is a special type, the T wave inversion. The first part is negative. You can see in the V4, that is the first part is negative, followed by the positive. That is global in distribution, that is in all the leads it is present. Negative followed by positive, global in distribution, and QT is prolonged. QT is definitely prolonged in this disease. So company it keeps suggest this is due to the hypokalemia, and company it keeps also strongly suggest this can be due to the hypokalemia. So hypokalemia is one of the causes of the T inversion, and this is the characteristic of the T inversion case of the hypokalemia, that is negative followed by positive, negative followed by positive, global and prolonged QT interval are the company it keeps. So this is the so this is another example of the pacing ECG. So there will be some that is the T wave changes, and again this T wave changes like the preceding ECG. So this pacing ECG should always produce the discordant T wave, and these discordant T waves is also accompanied by the prolonged QT interval. So this pacemaker patient has got some abnormalities of the potassium also, that is the hypokalemia. So this is a paced rhythm in presence of the hypokalemia producing such type of the T wave changes in case of the so another is the ischemic T inversion. The ischemic T inversion, there are two causes of the ischemic T inversion, either the subendocardial ischemia or the transmural ischemia. Subendocardial or transmural. In case of the subendocardial ischemia, there will be the exaggeration of the normal physiology. Exaggeration of the normal physiology. There will be ST depression and the T wave will be tall. But in case of the transmural ischemia, the T wave will be inverted, symmetrical and pointed. So this is the transmural ischemia. This is one of the example. Here you can see this is the T wave is inverted, pointed and symmetrical. This is that this limb is longer and this limb is shorter, but these are the symmetrical. If you can increase the length, so the left part and the right part will be the similar. So this is the symmetrical. That is symmetrically deep pointed T wave inversion is a criteria of the transmural ischemia. So this is one of the example of the transmural ischemia. This is another example of the T wave inversion where the T wave is pointed deep. So this is the T wave inversion. So here also the company it keeps follows the that there is some criteria of the LVH, the late ventricular hypertrophy. This T wave inversion is also accompanied by the some criteria of the late ventricular hypertrophy, and there is no T inversion in case of the V5, that is V1, that should be negative, but here it is positive. So this is the T wave inversion in presence of the late ventricular hypertrophy, and the differential diagnosis of the late ventricular hypertrophy, hypertrophic cardiomyopathy, acute ischemia, metabolic cause, cerebrovascular accident, and some draft brigade, particularly the tricyclic antidepressant. But this is characteristic of the late ventricular hypertrophy in presence of the hypertrophic cardiomyopathy. So basically, this is the it follows the criteria of the hypertrophy, that is the hypertrophy, and these are the differential diagnosis. And most of the time, this is the late ventricular hypertrophy or the acute that is the hypertrophic cardiomyopathy. But it should not be the acute ischemia. Acute ischemia can be excluded as because the T waves are symmetrical. If you can draw this line, the T wave is symmetrical. So presence of the symmetrical T wave inversion excludes the. So this is the way by which we can differentiate it from the acute ischemia. So this is the deep T wave inversion, particularly present in case of the late ventricular hypertrophy or the hypertrophic cardiomyopathy. This is another example when such type of the T wave inversion presents in presence of the LVS criteria. There will be downsloping ST depression. This is the downsloping ST depression, particularly deep T inversion. This is called the strain pattern. So strain pattern means LVS plus this criteria, that is presence of the LVS criteria and downsloping ST depression plus deep T inversion. When LVS criteria is associated with these criteria, this ST depression criteria and the T wave criteria, then this will be the strain criteria. So this is the late ventricular hypertrophy with strain, either because of the late ventricular hypertrophy, some other causes, or particularly or from the hypertrophic cardiomyopathy. So this is the actually late ventricular hypertrophy with strain pattern. So the T wave inversion is deep, pointed, without with or without the strain criteria. This is another example. This is the bifid P wave. Bifid P wave. You can see there is a two humps of the T wave. Two humps of the T wave. These are the particularly in case of the second degree AV block or non-contacted P waves. When this P wave actually positioned over the some parts of the T wave, then it produces this such type of the T wave. So this is called the bifid T wave. This is one of the example of the bifid T wave is because of the secondary, that is the second degree AV block. This is another example of the T wave. When the T wave are present, that is the T inversion, that is the T waves are inverted here. That is V4, V5, V6, and some other leads lead 1. But these are less than 3 millimeter. When the T wave is present less than 3 millimeter in height and does not fulfill the other criteria by the company it keeps, as for example, there is no other criteria to define the company it keeps, that is this T wave, then these are called the non-specific T wave. So less than 3 millimeter T inversion without any other criteria to define it, then it is called the non-specific T wave changes. So this is also one of the T wave changes. And this is another example of the T wave changes when the T waves are very much difficult to define. These are the T waves at the flat. This can be the position of the T wave. This can be the position of the T waves, but the T waves at the flat. So this is called the flat T waves. This is also one kind of the abnormality of the T waves. And another abnormality of the T waves is the NTTW-V1, that is new tall T wave in V1. This is one of the abnormalities of the T wave. That is, T wave is physiologically negative in V1, but here the T wave is positive in V1. The tall T wave in V1 may be normal, left ventricular hypertrophy, bundle branch block, or acute coronary syndrome. But when this type of the T wave is present with the symptoms of the acute coronary syndrome, then it suggests the coronary artery disease. That is, new tall T wave in V1 plus angina, coronary artery disease, or tall T wave in V1 is greater than V6. That is, the amplitude of the T wave should not be greater than the amplitude of the V6 of T wave. So when the T wave amplitude is V1 is greater than that of the T wave in V6, this is called the tall T wave. V in V1 is greater than the tall T wave in V6. This is also suggests the coronary artery disease, particularly LAD disease. But this all should be in presence of the symptoms of the acute coronary syndrome, in presence of the syndrome. Otherwise, this can be, this type of the T wave may be normal, LVS, bundle branch block. But when it present with the symptoms, then these are the very much important. So there is another types of the T wave abnormalities, that is the T wave alternance. You can see this is the amplitude of the T wave, this is the amplitude of the T wave, this is the amplitude of the T wave. There is bit-to-bit alteration of the T wave amplitude. And that indicates the bit-to-bit dispersion of the repolarization of the myocardium. And this is one of the arrhythmogenic factor and is many times related with the sudden cardiac death. So this is another example of the T wave abnormalities. So finally, the take-home message is that there are several types of the T wave abnormalities, particularly the tall T waves, either because of the hyperkalemia or hyperacute ischemia, or biphasic T wave, again hyperkalemia or hyperacute ischemia, that is the hypokalemia, or bifid T wave because of the second degree AV block, or inverted T wave with either ischemia or secondary changes. And these are the different varieties of the common varieties of the T wave changes, and some other rare varieties of the T wave changes, that is the non-specific T wave, flat T waves, T wave alternates, D Winters T wave, or the Whelan's T wave. And T wave interpretation is very much important, but always it must include the clinical data, company it keeps, and we should remember the T wave changes is not always ischemic. There are some other causes other than the ischemia. And finally, this is the main message is that T wave is ECG is very much important and considered as the underdog in ECG. T wave is the underdog in ECG for interpretation. Thank you very much for your patience hearing.
Thank you, Atahar bhai.
I think this is a very nice review. I'm Dr. Aziz Haq. And you're right on that, T wave abnormality, we always have to keep in context of the clinical picture. Any dynamic T wave changes, you have to be very careful if any dynamic T wave changes. And always if you have compared with the previous ECG and also compare with the clinical context, that's a very important point. Second point I'd like to make, that it's always confusing. That's for the trainees. I'm just, when you look at the axis of the T wave, we understand that the depolarization starts from the endocardial area. It moves to the more epicardial area. Okay, that's the direction of the depolarization wave. But the depolarization we see in normal condition, it starts from the epicardial area, goes down, goes towards the endocardial area. So that's maybe it's confusing to understand that, because we might theoretically think about, okay, why is the depolarization starts after the depolarization will start after that. So it should theoretically should begin from the endocardium going to the epicardium, but it does happen in the opposite way actually. The main reason that I think that Rafique Bhai can also attribute, or Atahar Bhai can attribute to that, main reason probably because of the circulation that we have, epicardial artery is bigger in the epicardium. The circulation, blood flow is bigger in the epicardial area. That's why those cells have better access to the electrolytes, quickly equilibrate the membrane of the cells and can repolarize quicker. And that's the reason we see in normal condition, the repolarization happens from the epicardium to the endocardial direction. I'm not sure, Dr. Rafique Ahmed and Dr. Atahar Ali, you can just explain that a little bit, but that's my understanding of that. Because otherwise it's kind of confusing, because depolarization starts from the endocardium, then we think that maybe repolarization will start on the endocardium and go to the epicardium, but it doesn't happen that way. It happens the opposite way. Rafique Bhai, I know, or Atahar Bhai? Okay.
No, I think you're right. I think going too deep into the mechanism will be beyond the scope of this talk today. And so I think we should continue with if there are any questions. If there are any questions, but I thought that was a very good talk. And but the interesting part, like anything in ECG, the dynamic nature is very important. That's one. Second, clinical picture. And of course, the other nitty-gritty of the ECG is that I always believe that if you keep looking at ECGs, then it's a pictogram. You suddenly look at a picture and recognize what it is, and then you explode it. Thank you.
Shafique.
One comment I'll be making that you should be expecting the T wave should be negative in P1. If it is positive, there is something wrong. For example, in case of acute chest pain, and you are having obviously apparently normal ECG, but you get a very good T wave in V1, V2. That should not be there. Normally, V1, V2 gets very smallish T waves. And if it is there, look at R wave. You may get a tall R wave. Then do the posterior ECG, posterior leads, and we'll find out you are actually dealing with a true posterior MI. That can happen. And we should remember that. And the second point is, as Sar was saying, in case of acute chest pain syndrome, look at the dynamism of the dynamic changes of the T waves. If it is there, the disease activity is there, it's an acute coronary syndrome, no doubt about it. You may not have the troponin immediately available, but still you can really start alerting the cath lab or taking proper precaution for thrombolysis or whatever, or anticoagulation as needed. That you can do.
I think Dr. Wadud, it's a very important point, because as we see that if you take like isolated T wave changes in non-ST elevation acute coronary syndrome, there's 14 to 27% isolated T wave abnormality, 14 to 27%. And if you look at that T wave inversion that we normally see, or biphasic or T wave inversion, the reason troponin might not be elevated, because as they studied, I think I remember one article from 2018, they compared that the different kind of ST and T wave changes and the outcome of these patients, what kind of disease they have, mortality, and they have in 6 months and a year. And looks like the T wave inversion was the most significant one. most significant one to correlate for, significant of coronary artery disease and mortality. And the reason that initially might not find like troponin elevation, because initial phase of T-wave inversion relates to myocardial edema, not injury yet, myocardial edema. And that has been shown in a very nice article in 2018 by MRI, cardiac MRI. They looked at that myocardial edema is present when the T-wave inversion in acute ischemia happens. And later phase, they go to injury pattern. So the myocardial edema is very important because that is a precursor for myocardial injury, necrosis for the future. So that's why T-wave inversion is very important clinically. If you see that, and particularly the dynamic T-wave that you mentioned, to be more alert, we need to be more alert on that there's definitely some coronary artery disease going on and dynamic in nature, because sometimes stuttering, blood flow back and forth going on in that direction.
What about Shafique?
Sir, I think we should be going on to the next. Atahar Bhai, it was a very good lecture. I really enjoyed it.
Thank you, Wadud Bhai. So, Shafique, please.
Shafique, are you here?
Yes.
Yeah, please. You can start sharing. We are going for the next session, case-based discussion, and today's presenter is our Dr. Shafique. He's become very famous for presenting beautiful and very interesting cases.
Thank you, sir. Thank you for a great introduction, sir. Actually, today might not be make all the test for the audience, but I am going to discuss few ECGs. This is a ECG, male 71 years, hypertension, diabetes, post-PCI patient. Chest pain on minimum exertion. I came to my chamber and I did the angiogram. So I just want to know what would be the coronary relation for this patient, either LCX, LAD proximal, left main disease, triple basal disease, or nano. So I just want to know a patient having chest pain on minimum exertion. So where could be the lesion? Patient having previous standing on left main to LAD, and that is bifurcation lesion, LCX. So Ribu, can we get the poll, please?
Yes, sir. Starting. Kamul bhai, please start the poll.
One, two, three, four, or the participant can.
Not getting poll still. If poll is not possible, can we get someone fellows to discuss the ECG, please, and predict the lesion in the coronary could be?
So any volunteer? You can raise your hand, volunteer, please. Is there a Nepali friend?
Oh, a poll already been given. So LAD proximal is the maximum answers. Right. Let's see what has actually happened in this patient. So there is a severe disease, left main disease with LCX 99%, LAD 90%, and left main 90%. So this patient actually and does not have any support from the RCA even. This patient developed severe chest pain in the night. I recommended urgent CBG, and patient was waiting for the next CBG. Patient developed severe chest pain, and patient is in shock at night. So surgeon has to come to do CBG in the night, and CBG done at night. Just a few days back, I did the angiogram. So this is very important thing is that if we look into the ECG again, definitely this is a LBBB, and at the same time there is some ST elevation in AVR and V1, V2 as well. And more important is that patient having chest pain on minimum exertion. And one thing I already told, patient having stent in left main 2 LAD and LCX bifurcation. So that one of the clue point, where could be the disease. That is very important for this patient group. But ECG does not totally fit with left main. Am I clear, sir? If, sir, from
Perfect.
the, yes, sir.
Perfect. First something, what I learned by reading ECG books, if there is left membrane clot, it's very difficult to identify which vessel is involved. Definitely it is LAD most likely because of left membrane clot as it supplies the vesicles. But it is very difficult to discern whether this is which artery is involved. And secondly, ST elevation in B1 is minimal.
Minimal.
Minimal. And normal patient may have QS pattern with this type of ST elevation. So in LVB, if you want to diagnose acute MI, at least 5 millimeter elevation is required according to the criteria. So far, I remember.
Now, this is to some extent. This is to some extent stable angina, and patient developed. Patient was unstable after angiogram.
And again, another thing is, I did several angiograms with this type of LVB with normal coronary.
Right, but that is why I have given some clues.
Now,
Patient having stent
left coronary block always indicates there is some underlying either coronary artery disease or myocardial disease.
But patient having the clinical symptoms
of maybe normal coronary disease.
Right, could be. And still patient having a chest pain on minimum exertion.
Yeah.
With stent in left main 2 LAD and LCX.
Clinical symptom is very suggestive.
Very suggestive.
Critical.
The only ECG is not suggestive, but symptom is very much suggestive.
Rafique sir, Assalamu alaikum.
Thank you. So I think this is interesting because again, it brings us to, if I gave this ECG without any history, we will not think much about it, as Jamil mentioned. But so the clinical scenario, but one of the interesting things that after the cardiac cath, what we would have done, we would have put a balloon pump in this patient. And that would have hopefully prevented this in the middle of the night cabbage, give us some time. So that's one thing that we do with this kind of left main patients.
Rafique sir, I have a question to you, if you don't mind, sir. Sir, can I ask you a question?
Sure.
Sir, in presence of LBBB,
yes,
with chest pain also,
yes,
can we think of any other artery than LAD, LCX, or left main?
With this ECG?
Can we think about RCA in any way?
Well, with this ECG, it's a wild guess. I think the answer that the participants gave, I think, was pretty good answer because it was a random pick. I mean, I just wonder one thing. This is theoretical, that if you look at V6, V5, the T wave is positive terminally. Normally in left bundle, it is negative. Whether it means anything or not, I can't say, but that's kind of unusual for left bundle. Even in lead one, you can see the terminal part of the T wave is upright, but normally it's negative. I'm just an observation. I mean, there is no data on it, but normally we expect it to be negative.
Sir, basically my question was, আমার প্রশ্নটা ছিল যে এলবিবি থাকলে, এলবিবি যদি থাকে সেক্ষেত্রে আরসিএ ইনভলভমেন্ট হওয়ার কোনো চিন্তা করার কোনো সুযোগ আছে কিনা?
Of course, patient with left bundle can have RCA disease, right?
না, মানে যদি স্যার চেস্ট পেইন থাকে এরকম পেশেন্টের ক্ষেত্রে
Asif,
স্যার সেই ক্ষেত্রে
the point is just this type of ECG actually cannot pinpoint which artery is involved. A server saying this is a random guess.
Yes, sir. That's very true.
And just I will give you a scenario. Let's see a patient have 90% blockade in LAD and LCX, and the RC is the principal feeder vessel. Now, that used to have a 50% lesion that plaque ruptures and it gets blocked. ECG change will be like left main disease.
Definitely.
But the lesion is actually now, culprit lesion is now RC. So we should not pay too much attention to it. The point is, in this context, the main thing that you should take this as an SCS and you should take this patient to the cath lab as early as possible.
Again, one of the points that it happens all the time. When we say a patient is pain-free, it's such a vague definition. I always ask patients, Ali, do you have any funny feeling in your chest? If the patient tells me I am as good as I used to be 6 months ago, I said, fine. But if the patient said, look, I've just this funny thing I cannot describe, that means the patient is having chest pain. I think that's where we miss this patient, that we think that the patient is pain-free. It happens, even in my hospital, it happens, that patient sitting all night with this mild discomfort, and the hospitalist did not pay attention because patient was not complaining of pain. That's a good case.
Yes, sir. Female patient, 57 years, diabetes, hypertension, necessitated cardiac arrest. ECG initially was at atrial fibrillation at first ventricular rate. Patient having kidney totally shut down, no urine output. Patient is on hemodialysis and hospitalized for the last 2 months. Ejection fraction was 35%, diagnosed as a dilated cardiomyopathy and recently diagnosed. Patient is on aspirin, statin, amiodarone, beta blocker, digoxin, ARNI, electrolytes are normal. So this is the ECG. Actually, sir, lot of discussion to be needed for this ECG later on, sir. After getting the poll, whether it is sinus rhythm first degree AV block with supraventricular ectopics, or sinus rhythm with first degree AV block with occasional normal AV conduction, sinus rhythm first degree AV block with ventricular ectopics, or 2:1 AV block. With ventricular ectopic. Most of they are with sinus rhythm with first degree AV block with ventricular ectopic, and few are sinus rhythm first degree AV block with supraventricular ectopic.
And nobody said B.
Nobody said B. And sinus rhythm is first degree AV block with occasional normal AV conduction.
Yeah.
So this is really difficult ECG for me as well. I put the ECG for discussion purpose, and I could not. I'll be going with B. I'll be going with B, but nobody with me. That is a big question and big problem to me as well. So,
who is going to discuss this?
This. So it is a matter of discussion. Actually, first degree AV block is there, and this bit, whether it is sinus or supraventricular or ventricular, definitely it is not ventricular.
Okay.
Yes.
If you go with B, then my question is, with the normal peer interval QRS complex is a little bit wider than the other bits which has prolonged peer interval. But maybe the reason of this widening of the QRS.
It is not that much wider, a bit wider.
Little bit wider than the...
A bit wider. That is a question mark.
Yeah.
So, but if you look into the P wave character in the V1, this is biphasic.
Also in V2.
Sir.
Yep. So I think at the first glance,
yes, sir,
it is number C.
It is number C.
Okay.
Right.
But if you look at
P wave,
this QRS complex that we are considering PVC, there is a P wave before each of them.
Right, sir.
And with the same interval. And that is a big coincidence to happen. So yeah, I'm sure if I had this ECG, if I measure it, I'll find that the second PR interval is constant in all these Ys. So that makes me think there is a relation between these two. I mean, it can happen and how can I explain it? That because the initial RR is longer, and then it conducts aberrantly. It appears to be right bundle type of aberration, which fits in with aberrant.
Right bundle, right, sir.
Yes.
Right bundle.
So my bet will be this was sinus rhythm, first degree AV block with occasional normally AV conduction with aberration. I have seen similar ECGs with alternating right and left bundle branch block.
So can I ask a question?
Yes.
So in that case, in AVL, AVR, as well as in lead 1, the normally conductive QRS complex axis is opposite to the regular interval QRS complex. What would be the explanation for this?
Well, this patient is having ischemia, right?
Okay.
Look at the ST segment.
Sir, there is another question.
Yes. So significant
T wave. This is the T wave.
Yes.
This is the T wave. And this is because of digoxin toxicities.
This patient.
Right, sir.
That's the patient of the digoxin. So interesting.
Right,
so the patient is getting digoxin as well as beta blocker, amiodarone. All are getting this patient.
Yeah.
Patient already getting digoxin and patient kidney totally shut down. And
beta blocker, which beta blocker?
Beta blocker, carvedilol. Patient is getting carvedilol. Right.
So, I mean, in that case, with all this electrolyte abnormality, I think my bet is with the number 2, that it was sinus first degree AV block with conducted QRS with aberration. And because of all this thing going on, the aberration is not following any fantastic pattern. And also, if you look at the 12-lead ECG, V1, V2, V3, V4, the R wave is small initially, right?
Yes, sir.
Yes, so there's poor R position or lead position is not in the right place, one or the other. But of course, Jamil's point is well taken that how come this is not fitting in with the typical description of bundle branch block. And it's not, it is not. It is some form of, probably it will be better described as non-specific interventricular conduction. But my bet is with this conducted, because it's a big coincidence for this thing to happen in such a timely manner that the PR interval will be constant. But then saying that, we also have to keep that option open that this is a PVC, it's just because of the timing, it looks like conducted QRS complex. But I have seen similar ECGs in the past that patient came with 2-to-1 heart block, and then there was some conducted 1-to-1 conduction. And the first beat was narrow, second beat was left bundle. I've seen that kind of ECGs.
Sir,
Yes.
Rafique sir.
Yes.
Sir, because of the variation in the AV conduction, the
Yes.
first and the second one is a bit prolonged than the first one. Does this prolongation of the conduction through AV node change its conduction velocity on the third beat? Every third beat that is conducted with aberration that you say fits well, if we consider that.
Well, it's because of you can follow with the simple pattern of rate dependent aberration, because
Yes,
that beat is coming early, QRS complex. And it is just like any other rate dependent aberration, or we see all this aberrant conduction with supraventricular premature beat. It can fit into this same pattern. My bet is, but I'm surprised that nobody chose B. I wish one person has chosen B. This is the first time I've...
Sir, it's very hard to choose B because initially the PR is so prolonged. How can one PR is become so short? That is the
yes,
confusion.
But you know what is the good news in this answer? That nobody is choosing. So I'm thankful to the audience that they're not choosing it randomly. So that is the good news of this thing. And I think this is the beauty of this course, that the logical quick thinking would be C. And if somebody was choosing randomly, they would have, some of them would have chosen B, but they did not, which I'm happy about it. Thank you.
Thank you, sir. This is the digoxin level, 3.96.
Oh my God.
Female, 81 years. Hypertension, admitted 1 week back with shortness of breath. Troponin was positive, CAG done and was found normal. This is 1 week back, first admission. Then this is it was the ECG, and what would be the diagnosis? Atrial fibrillation with fast ventricular rate with right axis deviation, supraventricular tachycardia with right axis deviation, atrial flutter with variable AV block with right axis deviation, atrial flutter with variable AV block, no right axis deviation, and sinus arrhythmia. Ribu, can we get the poll, please? So if you can have a discussion, please. Atrial flutter with variable AV block with right axis deviation. And
so everybody has chosen all the choices this time.
Right, sir.
And everybody must have a point. I wish somebody would come up and talk to us. So nobody is talking. Do you want me to talk, or anybody, any other panelist? So I'm going to start with number 1. Choice number 1 is correct because it is irregularly irregular, but it is wrong because I can see the waves which looks like a sawtooth in lead 2-3 AVF. number B is correct if I look at the second part of the ECG. The chest leads looks regular and I cannot see anything else. So if I had just the chest leads at that point, I can call it a supraventricular tachycardia. Of course, atrial flutter is also supraventricular tachycardia. But if I look at the first part of the ECG, that takes it away. So that goes out. Atrial flutter with variable block, C and D, both are correct. And the question is there right axis deviation? So if we look at lead 1, initially it looks like that the positive and negative component are both same. If that was true, then it's 90 degrees, but it's a little bit more negative than positive. So that is right axis deviation. So I think the reason I presented it this way, that when you answer a question, there should be rationale for each answer. And I gave you rationale, and then I try to explain why that answer was not correct. And that will be a good way of analyzing this kind of ECG. Anybody else, any comment? Wadud?
The beauty of this ECG is the baseline. As you always say, the ECG interpretation is actually pattern recognition from your memory bank of pictograms. And that sawtooth appearance, that should be kept always in our mind. It should be fixed in there. And whenever we see this type of sawtooth, it's atrial flutter unless proved otherwise. The point is whether it is regular 2:1, 3:1 block or irregular block. That's another matter. That's the thing I would always be asking our students to do. And if you consider, suspect that it's a case of atrial flutter, sometimes in V1, in case of atrial fibrillation, we get wave that looks like flutter. Please look at lead 2 or AVF. If you do not see flutter waves clearly in there, it's more likely to be atrial fibrillation rather than flutter. And if it is present there, it's very likely to be atrial flutter. And if you are near the patient, you can do the carotid massage a little bit after auscultating, and then do the ECG. Increase the AV block, and you can see the flutter waves very clearly.
Thank you, sir. So after one week, patient again admitted in the hospital with chest pain and shortness of breath. Again, troponin is positive, maybe in the lower range. And what should I do then? CAG again. This is a sinus and T-wave inversion with long QT.
Did you do angiogram for the first time?
Right. First time angiogram was normal.
No.
Right. Now, is patient admitted again with shortness of breath and chest pain as well. ECG, this is the ECG, patient admitted again.
So did the patient go home on any antiarrhythmic, amiodarone?
Patient was on, no sir, patient was on beta blocker.
Any anticoagulation?
Anticoagulation patient was getting, right sir.
And
Zaman.
And no neurological symptom?
No neurological symptom. Patient is very conscious, oriented.
Do you have any previous EKG on the previous admission 1 week before?
This is the ECG.
Ah, this is the EKG. Okay.
Right.
Mm-hmm.
So we did angiogram again.
No, let's talk about it. So what are the possibilities with this ECG?
Right.
One will be that maybe the reason I asked neurologic symptom, they symmet T inversion extensive and deep. Sometimes we see it in CVA. That's one thing that I thought of. Sometimes it happens.
Right.
Second will be an ischemic event. But how can somebody have ischemic event where the normal coronary is? But one thing that we have to keep in mind, patient was in flutter, is it possible that there is a clot there and dislodged and went into the coronary arteries? So let's see what you found.
Another point is maybe myocarditis. Myocarditis led to active flutter as well as this type of inversion.
Actually, QT is prolonged. That is why I did the electrolyte and magnesium level, and it is also normal.
What was her blood count?
Then I decided the blood count is normal. Okay. And then I decided to do angiogram, but still it is normal. So I could not get.
Now, can I see the LV gram on this patient?
No, I did not do the LV gram.
Okay.
Echo was normal. Echo was normal, and I did the echo by myself, and his echo is normal with restrictive pattern of diastolic dysfunction.
The main concern is right now, it's very interesting because the patient came with flutter. You did not do cardioversion, right? You just put antiarrhythmic or some medication, right?
No, then patient was reverted to sinus, and patient was discharged.
And what medication she was on?
She was on beta blocker.
Beta blocker.
Beta blocker with anticoagulant was given.
Anticoagulant.
So it reverted spontaneously or by cardioversion?
No, spontaneously reverted to sinus.
The question right now that there is a spontaneous, when the patient converted to sinus rhythm, did she, when she came in, came in only with chest pain, any other symptoms, or only with chest pain?
Chest pain and shortness of breath as well. Actually, patient initially was admitted under chest specialist, and whenever troponin was positive, then shifted to me. And at that time we did the NT-proBNP, that was higher, and troponin was higher. So
when the patient converted, apparently the patient converted spontaneously, right? There is no cardioversion involved.
No, we have given beta blocker only.
Just only. I think there's a good likelihood that probably had a clot that Dr. Rafique Ahmed mentioned earlier. A small clot might have went to the coronaries. That's one possibility.
Right, but in angiogram we could not get.
It might have dissolved.
Yeah, well, right. Even though I mentioned clot, the thing about clot in AFib and flutter, these are very small clots that goes to the brain and then they expand. They are not big enough to block coronary, even though I put it as a consideration, but normally the clots are very, very small clots, right, Ajit? Because the one that goes to the brain.
Yeah, and actually I saw one patient I'm going to share. That patient had mitral valve issue, and there is and the patient had, mechanical mitral valve and had a similar EKG presentation. And the small tiny clot went to the coronaries because the coronaries are clean when you did that. But the patient had ST elevation initially, and then, subsequently that, but definitely clot can go there. That's, always possibility, because I don't see any other explanation though, because patient did not have, what do you call, Takotsubo cardiomyopathy, then you should have seen some pattern of the LV gram or echocardiogram.
Actually, that is why, that was my suspicion that patient might have Takotsubo type of cardiomyopathy. That is why I did the echocardiogram by myself.
Okay, that's interesting, yeah.
Right. I have the pictures of echocardiogram as well, but not uploaded here, but I have.
But the reason is I'm looking at the LV, the coronary angiogram right now. I see how the heart is moving. Looks like the patient has some sort of cardiomyopathy because the heart is not really squeezing well.
No, but diastolic dysfunction is there, but systolic dysfunction not there.
Yeah, but the shadow is not moving like vigorously or something. Okay, it's not LV gram though. I agree.
Sir, Rafique sir, I have a question, sir.
Yeah.
Sir, can it be memory effect, sir, after the termination of the?
Yeah, but it's after 1 week. After 1 week is a question.
Well, the memory effect happens when you pace the ventricle. If somebody was in ventricular tachycardia, you convert, you can see T inversion. Or somebody has been pacing. That is difficult to explain by just the memory effect. And it is such an extensive T inversion. And as I told you, it similarly looks like the EKG that we see in CVA. massive CVA with QT prolongation.
Right, sir. But I could not get the explanation. That is why I have given here.
That's interesting.
What was the potassium and magnesium level?
That was normal. That I did. Initially, I thought this is hypokalemia and hypomagnesemia could be.
Was she getting amiodarone?
Right?
No.
Not getting.
That's getting.
Not getting.
That's getting.
No, not getting amiodarone.
You know, but this a cath looks like patient has cardiomyopathy because I don't see the heart is moving much, even with the fluoroscopy.
No, I did the echocardiogram. I can show you the echocardiogram. Even.
No, it's okay. I believe you. But
No, I mean, if Aziz is correct, was the echo done same day or next day?
Echo done just before the angiogram. Just before.
So then Aziz, if it was takasubu, sometimes it can happen that you do the angiogram today and you do the echo tomorrow or day after tomorrow. And
I agree.
Function may improve, but this was done before the angiogram, so it's normal.
Then I have to suspect just clot. There's no other explanation. But the question right now, that deep T wave inversion normally we see.
Can you see the echocardiogram?
No, I believe you. I'm trying to figure it out because the shadow here doesn't move well. The fluoroscopy shadow.
You can see the echocardiogram.
Yeah. Okay.
Very good movement.
Good.
All right.
Thank you. I think we should move on, and we have been. It's almost 1.5 hours. I think it's time to. Dr. Shafique, you always bring good ECGs.
Very interesting. Okay.
Thank you, sir.
Okay.
Okay. Next, any more? No, sir.
I think, shall we stop? It's 1.5 hours now.
Okay, sir. Sure. Okay.
Yeah. Thanks. Thank you.
Thank you, sir. Thank you.
It is very interesting. Thank you.
Yeah.
Thank you.
As I have said, Shafique will always bring very interesting cases.
No.
Very entertaining and very challenging.
And sometimes I myself don't know what is could be the final diagnosis.
Sure.
স্যার আমরা ওই কথা বলছিলাম সামনে তো রমজান মাস আসছে, রমজান মাসে আমরা বোধহয় একটু বন্ধ রাখতে হবে স্যার।
জি অবশ্যই, আই থিংক সো।
রমজান মাসে তারাবির মিদে কঠিন হয়ে যাবে।
জি জি।
সো টাইমিংটার জন্য স্যার সমস্যা হয়ে যাচ্ছে আর কি।
After Eid we can start again.
Yes. Sure, we'll do that. So we'll see everybody after Eid and Ramjan. Thank you.
Thank you, sir.
দেশে আছেন না চলে গেছেন?
আমি দেশে তো এখন।
স্যার দেশে আছেন?
শুক্রবার
আপনাকে পাচ্ছি না আর কি, আপনি দেশে আছেন কিন্তু আপনাকে পাচ্ছি।
আমি গ্রামে ছিলাম, তোমাদের no noise pollution, no sound pollution, no water pollution, কলের পানি খাওয়া গেছে, টিউবওয়েলের কোনো প্রবলেম হয় নাই। So what better can you do? তার মধ্যে আমার ফোনও কেউ পাচ্ছিল না, ইভেন বেটার, একেবারে শান্তিতে ছিলাম। ঠিক আছে, কথা
রফিক স্যার, স্যার আমরা মঙ্গলবার কি মিট করতে পারি স্যার?
What is it?
Cell phone is very essential, but it's very nonsense device.
Yeah.
It rings always, anytime, anywhere.
তুষার কিছু বলছে?
স্যার বলছিলাম মঙ্গলবারে যদি স্যার আপনি ফ্রি থাকেন আমরা ক্যান উই মিট?
আমি এইবার বাদ দিতে চাচ্ছি, কারণ আমি মানে আই হ্যাভ টু ওয়েট। এবার আমার স্পেসিফিক্যালি ছিল যে কোনো মিটিং অ্যাটেন্ড করব, কিন্তু ওয়াদুদের মিটিং আমাকে অ্যাটেন্ড করতে হয়েছে।
স্যার আমরা যে কি খুশি আপনি জানেন না যে আপনারে পাওয়া গেছে।
জি ঠিক আছে, থ্যাংক ইউ।
থ্যাংক ইউ স্যার। এজল আমাদের প্রোগ্রামটা খুব ভালো হয়েছে স্যার।
হ্যাঁ খুব নাইস।
জুনিয়ররা 80টার উপরে প্রেজেন্ট করছে, শুধু জুনিয়ররাই।
গুড।
ছোট ছোট টপিক, ছোট ছোট কেস, ইন্টারেস্টিং জিনিস।
শিওর।
কম্পিটিশন সেটাই।
ঠিক আছে, কত দেখা হবে আবার।
আজিজ ভাই, ইটস গুড টু সি ইউ।
It's always welcome, and definitely I like this. আমি একটু ব্যস্ত ছিলাম, কিন্তু anyway কালকে আমার সঙ্গে কথা হলো otherwise আমি anyway I plan করছিলাম আজকে অ্যাটেন্ড করার। I'll definitely attend it. There's no question on that.
Thank you everybody and good night.